So with that, it's my pleasure to ask Andrew to share with us his tips on managing a good prognosis patient. Andrew.
Thank you, Prof, for your kind introduction. I'd like to thank media and the organizers for inviting me to give this talk. It is indeed an honor. So my brief my brief, I've been given an easy job. The difficult job of managing poor or low prognosis patient has been done by the previous two speakers. So my part is to talk about managing a good prognosis patient. So if you scan this, you will see this question. There's no real answer to this, but maybe I would like your opinion, because we all have an idea of what is a good prognosis patient. And then someone, or borderline, I've put the ages and the AMH as borderline. And I put in B, someone with an additional problem of maybe implantation problems, someone a bit older, but with a normal AMH, and someone that has a previous cycle and switched back a normal PGTA who didn't get pregnant. So like I said, there's no answer to this, but it's just food for thought. So going back to my talk, I'm talking about managing a good prognosis patient. So the first thing to do would be to define what is a good prognosis patient. Then we're going to go to the word managing. So I've taken the artistic license to talk about managing in terms of IVF. So we're not talking about diagnosis. We're not talking about other forms of treatment. And then we'll go through what is my opinion, why I've come to those opinions, and some conclusions. So like I said, we all have an idea of what a good prognosis patient is. Someone that walks in through the door and you said, oh, she's got pregnant before, she's just coming in because she got remarried and maybe the husband's got some poor sperm parameters. Then we're talking maybe about a patient that has got dyspareunia and then, just needs IVF because, again, maybe husband's got some poor sperm parameters. So these are the examples of good prognosis patients. But we still need to sort of define good prognosis patients. So unlike, poor responders, unlike low prognosis patients, we don't have any criteria. We don't have a Bologna criteria for good prognosis patients. We don't have somebody needs to come up with a group of good prognosis patients. Nobody has really done that, and for obvious reasons, but I can think of a very good reason why we should come up with a criteria for good prognosis patients. Let's say, in Sydney, where I am, we have 3 laboratories in 3 different places. And we are doing a comparing them in terms of their pregnancy rates, the lab maybe. So we need a group of what we define as good prognosis patients to compare like with like. So in the Singapore example, if you wanted to say, how is your lab doing? How is SGH lab doing compared to KKH, compared to NUH? Then, if you just publish all your pregnancy rates, then you're going to say, this is not like for like, NUH might have older patients or poorer AMH patients. So if you have a group that you've defined as good prognosis patient, maybe less than 36 years of age, collecting at least 6 eggs, okay, then you say, okay, let's do this as the group of good prognosis patients, and let's compare the labs. Is there anything we can learn? Okay, so because we don't have that, the other way of doing it is to say, what is a good prognosis patient? Someone that is not a poor responder. So Bologna criteria, or since I'm here, and the Poseidon group is in charge, maybe we should have not a low prognosis patient. So both the Bologna criteria and the Poseidon group includes age, includes AMH, includes previous cycles, more than a certain number of eggs. Okay, I've included, Chloe's been excellent organizer. Apparently this drawing is done by Chloe, so well done, I've included that. Okay, so again, we defined this good prognosis patient. That again, we're going to talk about treatment, managing these patients. And certain principles come to mind. I mean, I don't know the Latin equivalent. I'm sure our European friends can tell us, but first, do no harm. Okay, no harm. We're talking about two people now. We're talking about the patient herself and the pregnancy. And then I've defined this, and I've thought carefully about these words. A healthy singleton baby. Okay, so healthy in terms of, okay, whether we do frozen embryo transfer, getting macrosomic baby, singleton, because we should really be putting back one embryo. Minimal side effects, we're talking about, no OHSS, certainly no torsion of the ovaries. Mental, and I've highlighted mental for the woman. So this is our aim. I've highlighted mental because one of the main reasons, why a couple that comes in for an IVF treatment doesn't get pregnant at the end is because she gives up. Lots of studies, including those in Australia, we have this perinatal statistic units that keep a very close eye on all IVF cycles done in Australia, and we publish it every 3 years. And in that publication and this publication from Fertility and Sterility, just recent one, 2021, say up to 25% of patients will just give up, after the second cycle, and that can be changed. That can be changed if there's active management of it, decreased down to 10%. So the mental, so remember, we are managing good prognosis patients. We really want the patient to come back again if they are not pregnant. The other key thing about my talk, which I hope you will agree, is that I personally think that the lab is so much more important than the clinical aspects. Whatever clinical decision we do, whether it be LDR, antagonist, what drugs we use, is only a small contribution. Okay, I would say, if I had to put a figure on it, maybe 20% and 80% of it is the lab. So your quality of the lab, your quality control is so important in a case like this where, with managing good prognosis patients. So having said that, the main message, because we are managing good prognosis patient, is don't mess it up. Both for the patients, both for the babies, both for the pregnancies. I'm not going to talk about pre-IVF because that is also very important in terms of the managing of a good prognosis patient. You don't want to make the wrong diagnosis. If the patient just needs Clomid to get pregnant for ovulation induction, everything else being equal, that would be the best treatment. So I'm really going to talk about the middle part, which is the IVF part of it. I'm not going to talk about the post-IVF in terms of the pregnancy management. So if you look at the middle part of it, a lot of what I said, I'm very grateful to the previous two speakers who have brought up Cochrane database, brought up some research, but I will reiterate that I'm talking about good prognosis patients. So maybe don't, stand up and ask me the question, why don't we add growth hormone? Why don't we add the pill? Because this is not poor prognosis patients. This is not lower prognosis patient, poor responder. These are good prognosis patients. So going back to the first principles, first do no harm. And so I'm going to go through all of this, but it's going to be very quick because I'm just going to give you my opinion, and I will tell you why I've already gone through this in terms of looking at the research and why I've come to this conclusion. So I'll give you all the answers now. So in the interest of time, in case I run out of time, I actually can stop the talk now. But if we talk about agonist versus antagonist, I have put down antagonist. We talk about drugs, recombinant FSH. Again, we had a good discussion this morning about whether we need LH or not LH. But again, we are talking about good prognosis patients. We're talking about cost effectiveness. Okay, do we need to add LH? I would say, in my opinion, if the cost is not too much more, then just use LH from the beginning. I would put that in my conclusions. Adjuvants, and I'll show you the research which has already been shown. Whether you use androgens and growth hormones, again, good prognosis patients, do we need anything adjuvants? Answer probably no. Freeze-all versus fresh. A lot depends on clinical decision. I mean, if the patient is at risk of OHSS, then yes, definitely freeze-all. If the patient's progesterone rises in the luteal phase, then if you believe that, which I do, then you should think about freezing all in terms of improving your pregnancy rate. But on the other hand, if your laboratory frozen pregnancy or frozen protocols are not so good, then yes, put them back in early. We talk about frozen embryo transfer protocols, and again, I put down clinical reasons. I'll explain that. PGTA, I'll explain no, again, because we are good prognosis patients. Number of embryo transfer, almost want to say, we really shouldn't need to discuss this. And lastly, we talk about luteal phase support. So 8 of this, we'll just go it quickly. I mean, if you look at Cochrane, obviously there's no difference between the live birth rates. And live birth rates, as we have heard, is not the best indicator, but I think that we are all in the consensus that there is no difference between the two protocols. But there are still advantages using LDR, but for all intents and purposes, antagonist has the advantage that we can use the agonist trigger, and we also decrease. Even if we don't use the agonist trigger, antagonist will decrease the rate of OHSS. We use less drugs. So I would say antagonist on this. Which gonadotrophin and what dose? And there's a whole heap of gonadotropins that you use. You're marketed every day by all the different drugs. We're now up to recombinant. So, going backwards to use non-recombinant, has those issues with contamination in terms of also in terms of dosages and how strong they are, how accurate they are. So I would say recombinant, whether we add LH or not, is a different question, but I would say based on cost effectiveness, based on good prognosis, we probably don't need to. What is interesting about this dosage, or gonadotrophin and dosage, is these two studies based on this drug, Elonva and Recavel, which has said that you can actually just plan the starting dose for the patient based on the patient's AMH and weight. Okay, and those studies have been quite well supported. They've done in RCTs based on AMH and weight. You can put a starting dose, and not only that, for the Recavel studies, you can actually just continue that dose without even changing it. Okay, whether you believe it or not, but these are good prognosis patients, so there is an argument that whether we should make it simple for them instead of upping, downing, repeating blood tests, ultrasounds, because we want to try and make it simple. If they don't get pregnant, they will come back again. Adjuvants, I'll start by saying, reminding you that it is good prognosis patients, and all the things that we have put down maybe for patients that do not respond, maybe for patients that have recurrent implantation failures. But even in where there is evidence like embryo glue, the evidence is usually low quality evidence, needing more studies. So I would say probably no for this. Fresh versus freeze-all. So we are very lucky in this part of the world where where the studies, the big 2 studies in New England Journal have been done in in Vietnam and in China. So in China, they first did that study in 2016. They're the first one. So in patients with polycystic ovarian syndrome, they found that yes, the freeze-all does increase the pregnancy rates. But subsequently, when the Vietnamese study came out, these are very big numbers. And I think that really going forward, probably these really big RCTs can only be done in this part of the world where you really have big one center. So we're not talking about meta-analysis. One center RCTs can be done in this sort of part of the world where recruitment of patients is much easier. So to conclude, Land's Vietnamese study with big numbers showed that in ordinary patients, patients without PCO, there is no difference. So it really boils down to your lab, because if your lab doesn't have a good frozen embryo transfer cycle, please put it back in fresh. You don't want them to mess it up by freezing. And so the final decision whether you should freeze or fresh, I think would boil down to clinical decision. Frozen embryo transfers protocol. So maybe up to 2 years ago, we probably just said doesn't really matter which one you do. Obviously, if the patient doesn't have periods, she's postmenopausal, then we need some sort of HRT. But if she is ovulating or maybe not ovulating all the time, then you can consider other forms, stimulated or modified natural. Question now is that there is this theory that if you do not have a corpus luteum, then you will increase the risk of preeclampsia in the patient. So maybe we moved a little bit towards natural cycles, but I would still say, we're still early stages, and probably any of them based on your experience is fine. So PGTA is interesting. PGTA, my personal opinion about PGTA is that we're probably going to get there. We aren't there yet. We aren't there yet in terms that if you look at the current meta-analysis and then the big studies like the STAR studies, though there is no difference in terms of whether you actually do PGTA or you don't. If you look at the STAR analysis and you look at the subset of older patients, yes, maybe there is. But the problem with PGTA, as you know, is we're still not there yet in terms of the technology. Now, when we started with fish, there was lots of problems with fish, and fish studies showed that meta-analysis showed that you actually decrease the pregnancy rates. But as we moved up to CGH and next generation, we're getting more and more accurate. And I think as we get more and more accurate, yes, we will actually be putting back in embryos. And we now know more decisions about mosaicism, whether embryos should or should not be replaced. I think we will get to the stage where, yes, when we got what we say is a euploid embryo, yes, it will increase the chance of getting pregnant when you replace that in all patients, but we're not quite there yet. And we need to talk about the cost of PGTA plus the fact that you are going to biopsy the embryo and itself. Maybe again, you don't necessarily need to biopsy again with technology. We can, look at culture mediums and analyze, therefore, not just the inner cell mass. We're also analyzing the whole, not just the trophectoderm. We're also analyzing both the inner cell mass and the trophectoderm, so the whole embryo, if we look at culture medium and non-invasive PGT. So single embryo transfer, I really don't think we need to do a discussion. I was in the days when we're talking about 3 embryos versus 2 embryos. And then, there was this heated discussion. Yes, really in women that are more than 40 years old, done a few cycles, we should really put back 3 embryos. And I went through that discussion, that, debates. And nowadays, you would think nobody would even advocate putting back 3 embryos. So we're now at the stage of 2 versus 1. And I think if we move forward down the line, we'll be thinking at some stage, maybe 10 years from now, why did anyone ever think about putting 2 embryos at some stage? So I would say single embryo transfer, especially if your frozen protocols are, just as good. If your freezing embryo transfer pregnancy rate is just as good as your fresh, okay, then you should certainly, with the improvements in PGTA, more the reason why you should just put back one single embryo. types of progesterones, I think for a long time, apart from the USA, we have been using vaginal pessaries, vaginal progesterone pessaries. Recently, not recently, but 2020, with Grissinger's study saying that dihydrogesterone is an alternative, may even decrease pregnancy rates. That's come up. And then this study by the US, heavily criticized, but it did try and do a comparison of vaginal pessaries versus intramuscular progesterone, and that study did show that there was an increase in IM, in pregnancy rates with IM progesterone. But it's still a single study, and then many studies before that couldn't show that. The Cochrane certainly says that it doesn't really matter which one. So for the ease and for administration, I think vaginal pessary should be the way forward at the moment. So going back to the list and my justifications for the list. So the reason why I have been quite interested in this and looking at how we can manage good prognosis patient is about 7 years ago in Sydney, we started a low-cost infertility we broke away. So we had this premium infertility clinic, which is like every private clinic in Singapore. But we wanted, but it was still quite expensive. And there were patients that, needed IVF, either tubal factor, sperm issues that couldn't afford it. So we looked at ways that first of all, whether we can decrease costs, and decrease costs in Australia would be manpower and also egg collection under general anesthesia in a accredited hospital. So we tried to take that away. We collected it in the rooms without anesthesia and all that. But the other thing that we were interested in was making the protocol as simple as possible with the least cost to the patient, but still maintaining pregnancy, because like I said at the beginning, my thoughts are that the lab is the most important. So if we use the same lab, or at least the same quality controlled lab, that we should achieve the same pregnancies. So we came up with everyone starting on the oral contraceptive pill, and we talk about that in terms of managing cycles, synchronizing cycles, so we all can start on a certain day, and egg collections will be like, 10 egg collections in a particular day rather than egg collections 2 Monday, 2 Tuesday. So everyone started with the pill here. We did the antagonist, basically all the things that I've looked at, and make sure that, in terms of evidence-based medicine, this was as simple as it gets without compromising pregnancy rates. So in conclusion, the difficulty in defining a good prognosis patient, we need to define it. Again, why Bologna came up was that, everybody was doing studies on, poor responders, but what is a poor responder? So again, if you are going to define, doing studies on good prognosis patients, or you're going to compare, one lab with another lab, you're going to do quality control. Then the first thing to do is define a good prognosis patients. Once we've done that, then at this stage, in my opinion, having looked at the evidence, I believe that antagonist protocol with recombinant FSH with or without LH, fresh or frozen based on clinical reasons, and also based on the quality of your freezing protocol in your country of a single embryo as clinically indicated. Thank you very much.